Okay, let's unpack this with a quote that really frames our discussion today. It comes from John Dewey. Attention comes first. Learning after attention is focused. And learning is primarily action.
I love that.
That idea that true, impactful learning is active, that it's rooted in action and demands focused attention, is absolutely fundamental to understanding why healthcare education has shifted so dramatically over the last 2 decades.
It really has.
We're deep diving today into simulation-based education, or SBE, and it's just, it's exploded, not just as a teaching tool, but as the primary high-stakes way of improving complex clinical decision-making, performance, and ultimately patient safety across the entire spectrum of medical practice.
And what's so fascinating here, and the sources really bear this out, is that SBE's power isn't just about the emergence of these sophisticated, high-tech manikins or fancy VR headsets.
Right, it's not the toys.
It's not the toys at all. Its true strength lies in the incredibly rigorous theoretical structures and systematic evaluation methodologies that back up every single scenario. If you're going to replace real-world experience, you have to be able to statistically prove your method is effective.
Because lives are on the line.
Because lives are absolutely on the line. So our deep dive mission today is to unpack that hard evidence, the stuff that demonstrates SBE's power to create measurable statistical improvements across the board, in knowledge, in psychomotor skill, critical thinking, even in participant confidence.
And crucially, we're going to look at how these large, complex healthcare organizations actually measure and track this impact, right? Using these proven quality improvement frameworks to translate learning from the sim lab directly to the bedside.
That's the goal. That's the whole point.
And to really grasp the necessity and just the speed of this adoption of SBE, we have to recognize the historical moment that created the urgency. The Institute of Medicine, the IOM, played a crucial role here.
Oh, a massive role.
Their 1999 landmark report, To Err is Human. Building a safer health system was an absolute national wake-up call. It identified these severe systemic deficiencies in the traditional clinical model of healthcare education.
That old see one, do one, teach one model.
Exactly. That informal, unstructured, and frankly, high-risk approach.
Well, the problem with see one, do one, teach one is really twofold, right? First, it lacks any kind of standardization. So the quality of your experience varies wildly depending on who you're learning from that day.
And the second part is obvious. It puts the patient directly at risk during the learner's first, high-stress attempt at a procedure.
Precisely. The IOM report essentially mandated that the healthcare industry look outside its traditional models. It directly recommended using safe, reproducible, technology-enhanced environments to improve performance and cut down on errors caused by system failure and human error.
So that report provided the immediate institutional momentum. It was the push needed for widespread SBE adoption as a core safety strategy, not just some educational preference.
It shifted from a nice-to-have to a must-have.
So if the IOM report established the need for SBE based on these systemic safety deficiencies, how do we connect that history to a clear, actionable definition of what simulation actually is?
Well, we really rely on the definition from David Gaba, who's a recognized leader in the field. He correctly defined simulation not merely as a technology, but as a technique.
An instructional methodology.
Yes, exactly. This technique is explicitly designed to replace or amplify real clinical experiences with these guided, high-impact learning scenarios. These are often immersive, fully interactive, and they're so carefully crafted to evoke or replicate critical aspects of the real world.
So it's a huge spectrum.
A massive spectrum. It can range from complex, computerized mannequins and highly trained, standardized individuals, all the way to lifelike virtual environments, or even just carefully contrived social situations that mimic a specific patient problem or a high-stakes event.
So that requires a huge shift in focus then, away from the hardware of the mannequin and onto the rigorous instructional design.
That's where the true learning potential resides. That distinction technique, not just technology, is absolutely pivotal because it tells us that throwing money at a fancy simulator without a robust curriculum and evaluation is, well, it's useless.
It forces organizations to invest in the methodology, not just the machine.
Exactly.
Okay, so let's unpack SBE's functionality a bit further. If the IOM report established the necessity, what specific functions did researchers identify that proved its immense utility? The research consistently shows SBE is effective across 4 major distinct domains.
Oh, that's right. In these 4 domains, they really represent the full strategic utility of simulation in a modern healthcare organization. The first domain is assessment.
Yeah.
This is using simulations explicitly for high-stakes competency evaluation.
Sure.
Can the new resident or the nurse transitioning to the ICU or the student, can they execute a specific skill reliably under pressure and meet a predetermined measurable standard?
And simulation provides the only way to do that consistently and safely.
It's the only consistent, reproducible, and standardized environment where this kind of high-stakes testing can happen without endangering a real patient. It's absolutely crucial for credentialing and professional advancement.
Okay, so that's the first one, assessment. The second domain is the one most people probably think of, and that's education and teaching.
Right. Pure skill acquisition and cognitive training. But what's so critical for this domain is establishing the correct learning environment.
It has to be a safe space, psychologically.
The environment has to be supportive, non-judgmental, and, above all, respectful. Now, that doesn't mean you don't give constructive feedback. In fact, feedback is mandatory. But it has to allow learners the psychological safety to explore, to experiment, to fail safely, and make mistakes without penalty to a real patient.
That's a critical part of the process, right? Reminding learners that their performance in a simulation is an assessment of their training needs, not some final judgment on their overall clinical capability.
That framing is essential for reducing that debilitating performance anxiety. It lets them learn.
Okay, so we have assessment and education. The third domain is research. This is where simulation acts as the ultimate ethical and controlled sandbox.
That's a perfect way to put it. Because the scenario is reproducible and you can adjust the variables, researchers can study complex things that would be completely unethical or just impossible to study in a live hospital setting.
Like what?
Well, they can meticulously observe human factors, the impact of different teamwork dynamics, the efficacy of new clinical evaluations, or just the nuances of complex decision-making under high stress. You can adjust one variable, say you add an unexpected equipment failure, or you reduce the staffing level, and then you can rerun that scenario multiple times across different groups to measure the precise impact.
So you get statistically reliable data on how resilient your system is. And that leads perfectly into the fourth domain, systems integration, which is really the highest level of application. This is where SBE can achieve its maximum organizational impact. It's astounding to think a simulation can be used not just to train a nurse, but to fundamentally redesign a workflow or test the integrity of the whole organization.
This is moving way beyond individual training. We're talking about organizational engineering. It's using simulation as a powerful tool to improve the macro systems in which nurses and providers work.
So things like optimizing patient flow or standardizing care transfers between units.
Or stress testing new electronic health record policies, or even fundamentally changing the organizational culture toward proactive safety. The target here is resilience, safety metrics, risk management, enterprise-wide improvement.
Can you give me a concrete example? What does that look like in practice? How does a simulation actually redesign a system?
Well, the Society for Simulation in Healthcare defines this domain pretty rigorously. It's a program that shows consistent, planned, integrated, and iterative application of SBE methods combined with systems engineering and risk management. So, for example, a hospital might run an in situ simulation, meaning it happens in the real clinical area of a complex, multi-patient trauma arrival. The data they collect might reveal that the physical layout of the room requires the charge nurse to walk 40 extra steps to get a necessary piece of equipment.
Which slows down the whole code team.
Exactly. So the simulation didn't just train the staff. It exposed a physical organizational deficiency. And now you can fix it by just moving the equipment closer. That is organizational engineering through practice.
Wow. So the learning really shifts from did the provider remember the steps to did the system allow the provider to succeed?
That's the leap. And as we mentioned, SBE didn't just spring up spontaneously in healthcare. We can trace its conceptual roots back to the 20th century, specifically in aviation.
Right, flight simulation.
Aviation laid all the technological and conceptual groundwork. Flight simulators, which started as these partial trainers and evolved into full cockpit mock-ups, were essential for practicing non-routine, high-risk events. But the major conceptual model that healthcare borrowed came from crew resource management, or CRM.
That was in the late 1970s.
Right. After several high-profile airline disasters, aviation realized that most failures weren't technical. They were due to breakdowns in communication, leadership, and decision-making.
Human factors.
Human factors. And CRM training, which focuses on those non-technical skills, proved that high-stakes environments demand team-based training over just individual, siloed expertise. Healthcare adopted that model wholesale.
So let's trace the physical evolution of the devices themselves, starting with the very first ones.
The history shows a lot of universities and corporations working independently, but the journey really starts with the partial task trainer. The most famous example, of course, is Resuscitation.
The CPR dummy.
Right, which emerged in the 1940s and gained global recognition in the 1950s. It was a partial body device from Laerdal, and its significance was just profound. It provided a standardized, reproducible, and affordable device specifically for practicing CPR.
It allowed for mass, repetitive, standardized training that had just never been possible before.
Never. And the shift from training a single task to training complex, interactive patient management that came in the mid-1960s.
Right, with Sim1.
That's when the first full-body, high-fidelity mannequin simulator, Sim1, was developed for anesthesiology residents at USC. Sim1 was revolutionary because it was the first time a device could respond physiologically to interventions like intubation and ventilation. It could reflect changes in vital signs in real time.
So that moved simulation from simple rote memory training to complex physiological decision-making. It really set the stage for fields like anesthesia that require such rapid response.
Yeah, it did. But it's really important to stress that while Sim1 was way ahead of its time, mannequin-based simulators didn't gain significant commercial and educational momentum until much, much later.
Not until the 90s, really.
That's right. And as we said, the major catalyst for the explosion in mannequin growth wasn't a technical innovation. It was the IOM's 1999 report, To Err is Human. That report exposed the patient safety crisis and established the urgent need for consistent, reproducible educational models that only high-fidelity simulation could provide globally.
And that just pushed institutional investment into overdrive.
Completely. We can trace this corporate evolution through some specific pioneering milestones. Gomart, for example, was an early player, starting way back in 1949 with a childbirth simulator.
Recognizing the high-risk nature of obstetrics very early on.
Very early. And then simulades emerged in the 1960s, and they initially focused on Moulage products, those realistic 3D products used to simulate injuries, disease effects, and trauma.
So they were focused on increasing the physical fidelity and the emotional impact, even on low-tech mannequins.
Precisely. The trajectory really accelerates in the 1980s. The University of Florida began developing computer-based simulators, moving the intelligence of the patient from an external operator's control to internal programming.
And that collaboration really changed the game in terms of integrating cognitive skills. By the late 80s, Stanford had the KC simulator, which integrated anesthesia crisis resource management, or ACRM.
And ACRM wasn't just about technical skill. It taught things like team leadership, communication, resource utilization during a crisis. And that philosophy was formalized in the 92-94 collaboration between Stanford and CAE-Link, developing a full-body physiological modeling simulator that could adapt its response based on the trainee's actions.
And, of course, Laerdal continued to evolve, introducing its mid-90s full-body computer-controlled mannequins.
Then, as the century turned, we saw more specialization. Gamard introduced the Code Blue 3 and Noel childbirth simulators to model complex fetal and maternal distress. Simulades offered full EMT and paramedic simulators for pre-hospital and trauma environments.
And it all kind of climaxed in 2011 when CAE acquired MIDI Medical Education Technologies, Inc. That really consolidated the industry, focused on full human physiology and worldwide distribution.
Yeah, that was a huge moment. And that timeline is just this clear trajectory from simple task trainers aimed at individual skills to complex, physiologically modeled and globally integrated systems aimed at team and systems performance.
It's so clear that the technological advancements didn't lead the transformation. The theoretical and organizational need for safer practice forced the technology to catch up.
Precisely. And that brings us right to the methodology. Linking simulation learning experiences with a robust theoretical foundation is, well, it's non-negotiable. It provides the consistent, predictable structure you need to build effective curricula that consistently produce reliable outcomes.
And we established that simulation-based learning is fundamentally a type of experiential education.
Yes, and the most cited and foundational justification for using SBE comes directly from Kolb's theory of experiential learning. This theory doesn't just say learning by doing, it provides a structured process for how experience translates into permanent knowledge.
It's not just a catchphrase.
Not at all. Kolb's perspective defines learning as a continuous growth spiral. It combines 4 continuous non-sequential stages. It's a cycle that starts with the action.
Okay, walk us through it.
The first stage is concrete experience. That's the participant actually engaging in the simulation scenario. Second, they move to reflective observation. That's the debriefing, where they reflect on the experience, analyzing what they felt and observed.
Okay, so what happened and how did I feel?
Exactly. Third comes abstract conceptualization. They move beyond the scenario itself to think about the underlying principles, the theories, the clinical guidelines that should have guided their actions.
The why.
The why. And finally, active experimentation. They take those abstract concepts and plan how they will apply them in a future, real-world, or simulated practice.
So if we apply that to, say, a nurse managing a patient going into anaphylactic shock, the concrete experience is the frantic scenario itself.
Right.
The reflective observation is discussing the sequence of events with the facilitator during the debriefing. The abstract conceptualization is realizing the protocol says to administer epinephrine first, and I waited for the doctor's verbal order.
Exactly. And the active experimentation is going back into the next simulated scenario and immediately applying that epinephrine, acting on that new conceptual understanding. Simulation creates the immersive, engaging environment necessary to enter and drive that spiral of learning.
It forces the learner, through reflection and conceptualization, back into action. And to make that deep psychological learning possible, the participant has to agree to the terms of the simulated environment. This is that sociological concept, the fiction contract.
The fiction contract is absolutely essential for simulation as a social practice. The participant is explicitly asked to suspend disbelief. They know intellectually that the mannequin isn't a real person, but they are making a commitment to treat the setting, the patient's symptoms, and the scenario as true to real experience as possible. This commitment is what makes the experience psychologically salient and ensures the learning transfers.
And without the fiction contract, the participant stays detached and the learning outcomes just plummet.
They do. And it's critical to acknowledge that this high level of immersion, combined with the pressure of the scenario, often leads to reported participant stress-racing heartbeat, sweaty palms, tunnel vision.
That stress, the sources note, is a normal and expected part of the experience.
It is. In a way, it proves the participant has engaged in the fiction contract. But facilitators have to be expert guides, managing that stress to make sure it doesn't overwhelm or inhibit the participant's ability to learn. The environment has to be safe, and participants need to be educated to recognize the stress as a normal physiological reaction, thereby normalizing the whole process.
So beyond the individual's commitment, SBE is also the perfect vehicle for improving team performance. And that's where the shared mental model framework comes in.
The shared mental model is really the conceptual backbone for team training. It assesses the impact on attitudes and behaviors around communication and collaboration in complex environments. What's critical is that when a team has a strong shared mental model, the members share similar characteristics in how they interpret, anticipate, and process information about the task.
They're all on the same page, so to speak. They think alike, often without having to verbalize every single detail.
Precisely. They are operating with the same internal script, which makes their actions predictive for their teammates. The inputs are varied, a common understanding of the problem, clear roles, known member expertise, projected future events.
And all of that underpins what's called macrocognition.
Yes, macrocognition. The high-level mental processes used by teams for complex, collaborative, one-of-a-kind problem solving. It's not just four individuals thinking, it's a single cognitive unit thinking collectively and efficiently in a crisis.
Like a highly tuned jazz ensemble improvising together.
That's a great analogy. And simulation allows us to diagnose and fix the breakdowns in that shared model.
So now we get to the heart of linking theory to the actual content. SBE curricula intentionally connect specific psychological and organizational theories to common healthcare themes to maximize the impact. Let's look at how theory addresses a major source of error: communication.
Communication breakdown. This relates directly to the theory of egocentric heuristics. This is a powerful cognitive bias where healthcare providers greatly overestimate how well their words or their commands during a patient handoff were understood or retained by other team members.
We assume the clarity in our own head translated perfectly to the listener, especially when we're under stress.
We do. A concrete clinical example. Imagine a complex surgical case where the surgeon makes a subtle verbal remark about needing a specific instrument next. Under pressure, the scrub nurse is focused on the immediate task. The surgeon, operating under this bias, just assumes the nurse heard and processed that future need.
And when the instrument isn't ready 30 seconds later, the surgeon gets frustrated.
Right, but the root cause was the assumption that their internal clarity was shared externally. SBE uses methods, like video review, to force providers to counter this overestimation and actively verify understanding, closed-loop communication.
Okay, next, let's address the theme of error in healthcare and its theoretical link.
Error relates to agency theory. This discusses the potential for the shifting or diffusion of professional responsibility, where due to information gaps, one provider or the patient might not have access to all the needed information to judge care decisions.
Ah, so this sounds like it directly encourages that shift work mentality where my responsibility just ends when I shift does.
Exactly. My shift is over. The night crew is responsible now. SBE actively engages at a macro level to foster joint professional responsibility and systemic teamwork. By running scenarios that span a metaphorical shift change or involve multiple disciplines, we force the team to acknowledge shared accountability, regardless of who is physically present.
Which is essential for countering that dangerous fragmentation agency theory describes. And what about managing the complexity of modern healthcare? There are challenges like information management and team working.
Well, information management relates to what sociologists call coordination costs. In modern healthcare, these costs are huge. They describe the immense necessity for systems to manage increasingly complex patient populations, technology, and protocols.
So things like managing 3 different IT systems or 5 different handoff templates.
Exactly. Those costs can threaten patient safety. SBE helps optimize those processes to allow for things like bundle care that maintain safety without an excessive administrative burden. And teamworking, that relates to social science theories about diffusion of responsibility and supports techniques that combat apathy and encourage continuous team self-monitoring.
And the final theme, situational awareness, relates back to the overarching assessment of risk.
And that links us directly to Reason's 3-bucket model from 2004. This provides a systemic, non-punitive way to assess why an error or a near miss occurred. It views the potential for error in any situation in terms of deficiencies related to 3 distinct buckets, ensuring the analysis is comprehensive.
Okay, can you walk us through those 3 buckets?
Certainly. The first bucket is the professional. This covers individual-level failures, skill gaps, fatigue, lack of judgment, poor decision-making. The second bucket is the task. This covers inherent issues with the clinical action itself. The task was too complex, the time pressure was too high, the protocol was unfamiliar.
And the third bucket?
The third bucket is the environment. This looks at external organizational factors: equipment failure, system noise, poor organizational structure, insufficient staffing, or missing supplies. So if a provider makes a medication error in a simulation, they don't just say, "I messed up." That's the professional bucket. They have to use Reason's model to ask, was the task inherently complex because of multiple calculations? That's the task bucket. Or was the medication missing a standard label due to an organizational failure? That's the environment bucket.
Exactly. By applying this model in the debriefing, providers and organizations can systematically consider the inherent risk of a situation and identify where a system failure occurred, rather than just blaming the individual. It aligns perfectly with the non-judgmental ethos of effective SBE.
Okay, so moving from the theory to the execution, we need to cover the specific characteristics that transform a simple scenario into effective SBE. The research identifies 12 of these, but we're focusing on the 5 core features, starting with the most critical: feedback.
It is the cornerstone. Immediate feedback, usually delivered through a highly structured debriefing post-simulation, is historically the single most important and frequently cited characteristic of SBE required to promote effective learning and long-term skill retention. So let's detail that debriefing process. What structured elements make it so impactful beyond just saying, "You did well," or "You need to improve"?
A quality debriefing is a powerful, protected conversation. It's a structured or semi-structured discussion between participants and a facilitator, designed not just to criticize or praise, but to highlight the rationale behind the participants' actions and decisions.
And it has 3 phases, right?
Generally, yes. The description phase, which is what happened, the analysis phase, why did it happen, and the summary application phase, what will we do differently?
That analysis phase seems to be where the magic happens.
It is. During analysis, participants express their feelings, they reflect on their performance connecting right back to Kolb's model, and they receive non-judgmental feedback from the facilitator and their peers. This process promotes deep insight, significantly improves learner performance, and, critically, slows the natural decay of skills over time by addressing those emotional and cognitive gaps immediately.
So without the debriefing, the simulation is just an experience. With it, it becomes genuine learning.
That's the key.
Okay, Next, we dive into fidelity. We know it refers to the degree the simulation represents reality, but you mentioned the definition is imprecise. If technical fidelity is so expensive, is there ever a case where lower fidelity is actually educationally superior?
Absolutely. The confusion often lies in conflating high technical fidelity with high conceptual fidelity. The sources help us by breaking fidelity down into three distinct technical dimensions. First, physical fidelity, how accurately the physical aspects of the human body are replicated.
The look and feel.
Right. Second, environmental fidelity, the degree to which the setting or room is replicated, including sounds and lighting. Third, equipment fidelity, whether the specific medical equipment being used functions exactly like the real thing.
But the true measure of educational value, you're saying, is conceptual fidelity.
Correct. Conceptual fidelity is the intellectual realism of the scenario itself. The patient presentation, the clinical progression, the social dynamics. They must be believable and align perfectly with the learning objectives. You can have a $500,000 mannequin, but if the patient in the scenario responds bizarrely to a drug, the conceptual fidelity is low and the learning transfer is compromised.
So the goal isn't realism for its own sake, but realism that supports the educational objective. For instance, if the objective is just for a resident to practice effective verbal handoff communication, then a low-fidelity scenario using only vital signs on a whiteboard and verbal interaction might achieve very high conceptual fidelity for that specific goal. The facilitator has to choose the level of fidelity required to make the learning objective salient. Investing in high physical fidelity when only conceptual fidelity is needed is wasteful.
And sacrificing conceptual fidelity for a cool device is catastrophic to learning.
It is.
The third foundational characteristic is deliberate practice. This is where the learning becomes truly actionable and measurable. Deliberate practice is a powerful, highly structured methodology at the heart of SBE. It requires the learner to be an active participant engaged in the focused, repetitive performance of specific skills. It's not just doing a task over and over. It's practice designed specifically and systematically to improve performance toward a defined standard.
And the sources list 9 distinct features of deliberate practice that elevate it beyond mere repetition. What are some of those key requirements?
Well, the requirements are strict because they lead to mastery. It demands highly motivated learners. There must be well-defined learning objectives. You have to know exactly what you're trying to master. It has to have an appropriate level of difficulty challenging, but not so hard it causes cognitive overload.
And it involves focused, repetitive practice.
Focused, repetitive practice designed for skill refinement. And that repetition, coupled with informative feedback and reliable measurement, promotes immediate error correction and improved self-monitoring until the learner reaches a predetermined objective standard of mastery. It is the engine that drives skill acquisition in high-stakes environments.
And that mastery leads directly to the fourth core characteristic, reflective practice.
Reflection is cited as perhaps the most important part of the entire experience, especially for professional growth. Every simulated experience is a concrete event that offers an opportunity for reflection, connecting right back to Kolb's model.
It's that moment of self-examination, reviewing the simulation, connecting your actions to past clinical practice, and ultimately improving future practice.
Exactly. Post-simulation activities, particularly debriefing and self-reflection, embody this. However, this is where the research carries a critical warning, and it links back to the need for objective assessment. Studies examining the accuracy of self-reflection demonstrated the infamous accuracy gap.
The accuracy gap.
Yes, higher-performing participants in simulated scenarios more accurately rate their own performance during self-reflection compared to poor performers.
Wow. That's a devastating finding for self-assessment. If poor performers lack the expertise or insight to accurately recognize their own deficiencies, then relying solely on self-reflection data to assess competency is highly unreliable.
It is. It means accurate self-awareness is actually an advanced skill that has to be learned through deliberate practice and systematic external analysis. It confirms that while self-reflection is essential for learning and growth, it cannot be used reliably for high-stakes assessment or competency measurement. Your assessment tools must be objective and externally validated.
Okay, because the term simulation is a technique, not a technology. The modalities used are incredibly diverse.
So diverse. It all depends on the specific learning objective. Running through some examples really illustrates just how broad this field has become.
Let's start with the human elements, which often provide the highest level of what you called effective fidelity, live role players.
We have two primary types here. First, standardized patients, SPS. These are live individuals professionally coached to portray a patient with a specific condition, emotion, or background. They are used extensively for communication assessments, physical interviews, and pre-op education.
So they're vital for assessing those interpersonal skills.
Absolutely. Then you have embedded simulation persons, ESPs. These individuals are coached to act as other team members or maybe distracting family members or difficult colleagues. Their role is to interact with the learners and enhance the affective fidelity, the emotional, and social realism of a chaotic environment. They introduce realistic human factors.
Then we have training defined by its location, setting-specific training, which brings us back to systems integration.
Two main types here. In situ, simulation takes place in the actual clinical area where participants would normally function right on the hospital floor, in the real OR, or in the actual ICU. This ensures maximal environmental fidelity and immediately addresses system issues.
So running a cardiac arrest drill in situ might reveal that the defibrillator battery is always kept on low charge in that specific unit.
Exactly. The training exposed a system flaw, not just a staff skill gap.
But just-in-time training is for those low-volume, high-risk procedures.
This simulation is conducted immediately prior to a potential intervention, say practicing a complex central line insertion or an intubation just minutes before the real procedure. It maximizes the effectiveness of skill acquisition by leveraging the recency principle. Your skills are maximally retained right before the real event.
And finally, we see the technology blends becoming more and more sophisticated.
Hybrid simulation is common, using one type of simulation to enhance another, often combining a high-fidelity manikin with a standardized patient. So the SP might portray the emotional distress of a laboring mother, while a manikin is used for the complex shoulder dystocia procedure, capturing both the effective and technical challenges at the same time.
And then there's augmented reality.
Augmented reality, or AR, is a type of virtual reality where synthetic elements are superimposed on real-world objects. Think of a physical stethoscope that plays complex virtual heart sounds when you place it on a live standardized patient.
And the most complex blend is mixed reality humans, MRH.
MRH takes it even further. It combines a manikin or a task trainer with sophisticated virtual screen elements. So you might be using a partial task trainer for a complex surgical procedure, while a virtual screen simultaneously displays detailed internal anatomy or provides virtual team members for effective skills training.
So it's an attempt to merge the physical practice with the cognitive environment.
That's the idea.
All this effort, all this investment in equipment and training, it has to justify itself to organizational leadership. And this is where contemporary nurse leaders must align that simulation investment with the Institute for Healthcare Improvement's quadruple aim.
That's the strategic imperative. Leaders are always asking, what is the return on investment? The quadruple aim provides that framework, focusing on 4 areas: improving patient care, improving population health, reducing cost, and developing a more resilient workforce.
And it's been historically challenging to measure that ROI from simulation, right? Because the outcomes, like reduced mortality, are so far removed from the lab.
It's very difficult. Leaders have to grasp the underlying pedagogy and theory and use the right measurement tools to articulate simulation's value effectively, showing how improved skills translate to lower error rates and increased workforce satisfaction.
And the gold standard solution to measuring that long-term high-level impact is the translational science framework. This provides a structured path to measure the transfer of learning beyond the lab into observable organizational change.
Right. The framework adapts that bench-to-bedside concept into 3 distinct phases for educational research, helping to ensure researchers and leaders are measuring the right thing at the right time.
So let's track a single intervention, say training nurses on a new standardized protocol for preventing catheter-associated urinary tract infections, or COTIs, through these 3 phases.
Perfect example. T1 Simulation Lab is the initial step, assessing cognitive and psychomotor skills in the safe, controlled simulation environment. Here, we'd measure if the nurses accurately performed the new COTI bundle elements: sterile technique, proper dressing, correct documentation in a simulated scenario.
You're just ensuring skill acquisition before they touch a real patient.
Exactly. Then T2 is where the real difficulty and the real payoff begins: clinical practice.
This is where you see if the skills actually transfer.
T2 assesses whether those skills transfer into the clinical environment, resulting in measurable improvements in patient outcomes. For our CIUTI example, we would track the actual adherence rate to the new protocol on the floor over the next 3 months. Are nurses actually doing the bundle steps correctly on real patients?
And critically, that should lead to reduced CIUTI rates.
It should. This proves the intervention works in the real world. And the broadest impact is T3, focusing on public and policy impact.
This is where it goes system-wide.
T3 translates those proven patient practice outcomes into established organizational protocols and eventually public health policies. For our example, if the T2 data shows a statistically significant drop in CIUTI rates, the hospital might mandate that training module annually for all staff.
And if multiple hospitals show similar results, that practice might become a national standard.
Precisely. That's the transfer of patient practice outcomes into mandated policy and organizational compliance, ultimately improving societal health. The challenge for future research is continuing to measure T3 outcomes, especially in complex areas like communication skills or end-of-life care, where setting clear benchmarks is inherently difficult.
So the operationalization of SBE evaluation has to be systematic, purposeful, and planned from the very beginning. You can't just retrofit evaluation after the fact.
No, it has to be built in. It should follow a process similar to the continuous improvement cycle of Plan, Do, Study, Act, PDSA, starting with a clear rationale, measurable learning objectives, and performing a pilot or a dry run to correct any glitches before you go live.
And once a program is running, the evaluation process often relies on revisiting Kirkpatrick's 4-level evaluation model.
Which is the canonical standard for assessing training interventions. We know Level 1 reaction measures participant satisfaction, the happy sheets, and Level 2 learning measures skill and knowledge change, often via pre- and post-tests.
But the real strategic challenge is in measuring the higher levels.
That's where SBE needs to focus its rigor. Level 3, behavior, addresses the transfer of knowledge and skills into actual practice. This is about observing whether the learning sticks and is applied when the learner leaves the lab.
And that's really difficult to measure.
It's very difficult. It often requires long-term direct observation in the clinical environment, which is resource-intensive and often disruptive. And Level 4, results, examines the ultimate impact on the organization, which is the most difficult and lagged measurement.
Because you need complex data, statistically reliable clinical outcomes, or improved organizational metrics.
Right. Reduced mortality rates, decreased length of stay, reduced cost of care. These results often take 6 months or more to obtain after the program is done because systems just take time to show statistical shifts.
Okay, so to maintain clarity, we must constantly draw a distinction between two objectives of measurement. Program evaluation focuses on the worth of the program itself.
Was the SBE curriculum effective?
And assessment focuses on the competency of the learner.
Did this specific person achieve mastery? And critically, a finding that must be stressed again because it governs the design of all reliable assessment tools. Self-assessment data offers little or no reliable indicator of competency and should not be used in high-stakes assessment.
Because of that accuracy gap we talked about.
Exactly. We cannot rely on the learner's perception of their performance. Assessment tools must be rigorously structured, tested for validity and reliability, and measured by objective external criteria.
So let's detail those rigorous assessment tools, the checklists and rating scales that are designed to observe and rate performance objectively.
We rely on two main types. First, checklists. These consist of statements reflecting observable, usually procedural behaviors, scored typically as done or not done. They're highly effective for tracking psychomotor skills, like surgical scrub technique or the steps of defibrillation.
And a significant advancement is the weighted checklist.
Yes, where items deemed more critical for a successful patient outcome are assigned greater value or weight. This helps reliably discriminate between high ability and low ability performance.
So, did the provider check for airway patency? Might be weighted 3 times higher than did the provider introduce themselves properly.
Exactly. And that weighting often requires a specific expert consensus method like the Delphi process to distill what the most important behaviors are and assign their value, ensuring the assessment reflects genuine clinical priority.
Okay, and the second type is for situations that are less procedural and more dynamic, where judgment and communication and leadership are paramount.
Those are the global rating scales, GRS. GRS are used when the situation is dynamic or lacks a single best action, like in complex crisis-simulated scenarios, or when assessing complex non-technical skills like leadership and resource management.
The ACRM behaviors.
The ACRM behaviors, they typically use a Likert type scale, often 5 points, which allows raters to assess how well the performance was executed. For example, the provider demonstrated excellent situational awareness, rated from 1, poor, to 5, excellent. GRS are absolutely critical for evaluating those non-technical skills that binary checklists just cannot capture.
Finally, let's connect this meticulous analysis of SBE evaluation data to the larger organizational effort. This data is the input for the Institute for Healthcare Improvement's IHI QI Essentials Toolkit.
Yes, a set of 10 core tools used across quality improvement methodologies like Lean and Six Sigma. The simulation team needs to be fluent in these tools to translate their lab findings into actionable organizational change. Let's run through a few examples. We can start with the cause and effect diagram or the fishbone diagram.
The root cause analysis tool. So if SBE repeatedly exposes a breakdown in the system, how does the fishbone help?
Well, if simulation data consistently shows, for example, high rates of medication delay during chaotic scenarios, the fishbone diagram helps the team methodically analyze all contributing causes across 6 major categories: man, machine, methods, measurement, materials, and environment.
It prevents the team from jumping to a superficial conclusion.
Exactly. It forces them to find the true root organizational deficiency that led to the repeated failure in the simulation.
And the failure modes and effects analysis, FMEA, takes a proactive stance.
FMEA is crucial for safety and risk management. It's a systematic, proactive method for identifying where potential failure modes might occur in a new system or process, say, a new care transfer protocol learned in simulation. The team assesses the probability and impact of that failure, calculates a risk priority number, and then prioritizes mitigation efforts before the failure impacts a real patient.
So it makes the simulation data immediately valuable for proactive risk reduction.
Immediately. And for understanding the impact of their training interventions, they need run charts and control charts. This is often where leadership needs clarification. What's the difference?
Let's hear it.
They're both essential monitoring tools. A run chart simply tracks performance over time, looking for non-random trends. For example, tracking the percentage of successful intubations week over week. It shows if things are generally getting better or worse.
Okay.
A control chart, however, is a more sophisticated statistical tool. It adds calculated statistical boundaries, upper and lower control limits, to that run chart data.
And what do those limits tell us?
They help the team understand variation. Specifically, they identify when a change in performance is a special cause, meaning it's an actual statistically reliable result of the new simulation-based training versus common cause variation, which is just normal random system fluctuation.
And for leadership, that distinction is critical. A statistically significant change caused by the SBE intervention validates the training investment.
It proves ROI. Finally, the Pareto chart keeps the simulation team focused on the highest impact issues identified in the lab.
This is the 80-20 principle.
The 80-20 principle. The vast majority of problems are caused by a small minority of inputs. It helps teams identify the vital few highest priority areas to work on. If 85% of medication errors in the simulation are traced back to just 2 systemic problems, poor handoffs and low staffing on weekends, the Pareto chart ensures that organizational resources are focused exclusively on fixing those 2 problems that will yield the maximum return in patient safety.
So if we synthesize the core message from this entire deep dive,
I think it's that SBE is not just a passing educational fad fueled by technology. It is a proven high-impact methodology for improving clinical outcomes when, and this is a big when, it is backed by rigorous theory like Kolb's, utilizes structured practices like deliberate practice and debriefing, and achieves organizational alignment through strategic frameworks like translational science and practical QI tools like the IHI toolkit.
so the structured integration of all these elements is what transforms individual learning into measurable, system-wide patient safety improvements.
Improvements that leaders can actually track on a control chart.
That structural rigor is astonishing. We've seen that high-fidelity simulation is essential, but it requires participants to intentionally suspend disbelief via that fiction contract to fully engage in the social, high-stakes teamwork environment. However, healthcare is rapidly adopting new, often dispersed training models. I'm thinking about the integration of widespread telehealth and highly individualized VR training, which often focus heavily on the individual provider interacting remotely.
And that raises a really important provocative question for the next generation of SBE research. If the future of training pushes learning further apart, focusing on the lone provider in a virtual space, maybe practicing a surgical procedure without a physical team present, how can healthcare systems ensure that the social experience and the shared mental models required for real-time, high-stakes teamwork remain paramount?
Right. We spend so much time establishing that true safety relies on the team's ability to operate as a single cognitive unit macrocognition. If technology pushes training further apart, focusing on technical mastery, what critical human skill, the ability to assess and integrate with a team you may have never met face-to-face, or a team that's geographically dispersed, must now be taught explicitly?
Taught explicitly to ensure that when a physical or virtual crisis occurs, the social practice of teamwork and the system integrity it supports remains whole.
That gap between techno mastery and collaborative durability in these dispersed or virtualized teams.
That is undoubtedly the next frontier for simulation research and training design.
An excellent thought to chew on as you consider how to lead change and optimize systems in your own domain. Thank you for joining us for this deep dive into simulation-based education. We hope you feel well-informed and ready to apply some of these powerful concepts, whether you use the structure of the Kirkpatrick model to evaluate a training you recently attended, or simply pull out a run chart to track an improvement area in your own professional life. Until next time.